Welcome everybody to the February Grand Rounds. I hope you enjoyed the format in January. We're going to do that again this month, looking at cases in particular more along the lines of a classic Grand Rounds from when we were in medical school or residency. Many of you have asked me what's up with our updates to the AME Guide that we've been doing for years on the last Wednesday of the month. We are navigating the new approval process for external guidance. The good news is the January updates have cleared through the initial hurdles in the government, and hopefully we'll be able to release those very soon. But as we learn from this process, we'll get back on the cadence that we've had in the past, so you'll begin to see the routine updates as we figure it all out moving forward. So you don't really want to hear from me tonight, but welcome again. We appreciate all you do because you truly are where the rubber meets the road for the safety of the national airspace. So with that, I'm going to hand it back to Christy, and I hope you enjoy this evening.
We are unable, because of accreditation, to be able to give you credit for watching the recording. So only people that attend the live presentation will receive credit. Next slide, please. Our objectives for this evening are pretty short. We're going to talk about some case studies related to low testosterone, low T, and hypogonadism. And then we're also going to discuss color vision screening. And with that, I'm going to go ahead and turn it over to Dr. Mathers. Thank you.
Thank you, Christy. Hello, everyone. Today, we're going to be talking about low testosterone hypogonadism cases. Next slide. Our first case is a 50-year-old first-class ATP who presents to your office for his biannual flight physical. Since his last exam, he started using topical testosterone. Upon further questioning, he reported seeing his PCP for symptoms of decreased energy and libido. The PCP checked his testosterone level on 2 occasions in the morning and found it to be low. He was started on a testosterone gel and reports significant improvement in symptoms. He is now asymptomatic, otherwise qualified, and screens negative for OSA on a stop-bang questionnaire. Next slide. So in this case, this is going to meet criteria for row A in the low testosterone hypogonadism table. Because the pilot is treated with topical testosterone only, if you as the AME can determine that the condition is under control, current medications are acceptable, and they have no symptoms that would interfere with flight or safety-related duties, you can go ahead and issue a medical certificate and annotate this information in Block 60. Next slide. Our second case is a 35-year-old third-class pilot who calls your office to schedule an exam. He is not due for 6 months and wants to make sure he has everything needed for the next exam. During pre-screening, he discloses that since his last medical, which was conducted 4.5 years ago, he has begun taking injectable testosterone. Upon further questioning, he says he saw his provider 2 years ago due to low libido, and his testosterone level was found to be low. So prior to scheduling the exam, what is the best next step? Next slide, please. So you're going to need to gather some additional information for this case, but it's looking like this pilot may be qualified for a CACI. He's treated with injectable testosterone, which is one of the medications listed under row B. They can also be taking oral testosterone, Testapel, which is the FDA-approved pellet, anastrozole, HCG, or clomiphene citrate. So you could give this pilot the CACI low testosterone hypogonadism worksheet and have him take it to his appointment with his primary care physician. He'll need a detailed clinical progress note from the treating physician and a complete blood count. Next slide. So case 2 continued. The pilot returns to your office 5 months later for his third-class medical renewal. He brings a detailed clinical progress note from his treating provider, stating that 4 months prior to today's exam, the pilot disclosed that he and his wife were trying to conceive. So his provider switched him from injectable testosterone to anastrozole and clomiphene citrate. He's done well in this new regimen, and his only side effect is mild acne. His BMI is 36, but there's no history of cardiovascular disease, venous thromboembolism, or prostate cancer. A CBC conducted 3 weeks ago shows a hematocrit of 50, and he has not required any phlebotomy. A follow-up note from his treating provider within the past 90 days deems his condition stable, and his OSA screening is negative. Next slide, please. So in addition to completing the CACI worksheet, what other question should you ask the pilot regarding this new medication regimen? Next slide, please. So this is the CACI low testosterone hypogonadism worksheet. So the first row says a current detailed clinical progress note from the treating physician is required and says must say that the condition is stable on the current regimen, no changes are recommended, and no side effects that would interfere with flight duties. This pilot had mild acne, and you can see under the note there that mild skin irritation and acne are acceptable. This pilot did not require treatment with phlebotomy, has no history of cardiovascular disease, thromboembolic events, or prostate cancer. The hematocrit was within the acceptable limit. And as you can see from the CACI, they can be on one or more of the following medications. So this pilot was initially on injectable testosterone, but then was switched to anastrozole and clomiphene citrate and has done well on this new regimen. So the additional question that you'd want to ask this pilot is to confirm that no visual side effects are present. Clomiphene citrate can be associated with visual side effects, so you'll want to make sure that you ask the pilot if they're present. It also requires a 14-day initial ground trial, which this pilot is well past. So in this case, if they meet all the criteria, you would put CACI qualified hypogonadism in block 60. Next slide, please. Okay, our last case is a 55-year-old first-class ATP who presents to your office for his medical renewal. His previous AME closed his practice, and since his last application, he reports the use of testosterone. Upon further inquiry, you discover he sought care from a low T center and was prescribed non-FDA approved bioidentical hormone pellets after a single testosterone measurement was low. He brings in a brief, handwritten note from his treating provider saying he's experienced great relief from this treatment. He undergoes regular follow-up and phlebotomy, and his only other medical history is hypertension, for which he is CACI qualified. Next slide, please. So this case is going to fall under row C. Because the pilot is treated with bioidentical hormones and is treated with phlebotomy, you're going to want to collect some additional information. Row C has a link to the blood donation page, so you can provide the pilot with information about wait times after blood donation. So this pilot is going to need to see their treating physician and provide either a low testosterone hypogonadism status summary or a current detailed clinical progress note generated from either a urologist, endocrinologist, or a treating physician, no more than 90 days prior to the AME exam. The requirements for the progress note are listed in the AME Guide, and you'll be required to defer the exam. Next slide, please. This just goes over the additional requirements for the detailed clinical progress note. And as you can see, it has to specifically include the current medications they're taking and a lab CBC performed no more than 90 days before the AME exam. We do have a AASI or AME assisted special issuance for pilots that are not CACI qualified to help speed up the certification process in these cases.
All right. Well, good evening. I'm Stephanie Robinson. I'm a legal instruments examiner here at the Aerospace Medical Certification Division in Oklahoma City. The group of examiners I work with here at AMCD review the applications that the AMEs, transmit to the FAA. The legal instrument examiners really appreciate the valuable work that you guys do, and we thank you for that. I was asked this evening to present some information to you about color vision screening and how you, the AME, can help us, the FAA, be more efficient in our review. Next slide. So, of course, we're going to mention the acceptable screenings, which you guys are all aware of. And then we're going to break down the different types of pilots that you're going to see coming into your office, the returning pilots, pilots with a letter of evidence or statement of demonstrated ability, those returning pilots who have limitation 16 or 17, and then your brand new pilot applicants who are coming in for the very first time. And then we're going to talk a little bit about color vision screening uploads. Next slide. So, of course, you guys know that beginning January 1st, aerospace medicine revised the color vision screening requirements, and only the three following tests are acceptable. That's the color assessment diagnosis, which is CAD, the Raven cone test, and the Wagner computerized color vision test. Next slide. So there'll be many returning pilots, and this is just to clarify, when those pilots who have already passed color vision on any previous exam, including our alternate test prior to January 1st, they do not need to repeat color vision screening on new applications performed after January 1st of this year. You'll be able to mark item 52 for color vision as pass, and of course, no color vision limitation is required. Next slide. For returning pilots who have a letter of evidence or a statement of demonstrated ability for color vision, they do not need to repeat the color vision screening on new applications either. Again, on these pilots, you're able to mark them as a pass, and they don't need a color vision limitation. Next slide. Returning pilots with a limitation 16 or 17, if they don't want it removed, they can continue to be issued the same class or lower with limitation 16 or 17 as appropriate. Now that limitation 16, that was applied to pilots who took an OCBT MFT in the past, and they only passed during nighttime flying. So that's why they are limited, not valid for flights requiring color vision control during daylight hours. And then you guys are all familiar with limitation 17, which is not valid for night flying or by color signal control. Next slide. So returning pilots with limitation 16 or 17, so they did not pass one of those previous tests, they can take one of the new acceptable tests that's performed in person. If they pass, you can mark item 52 as a pass, list in item 59 the color vision screening that was performed, and then no color vision limitation is required. For the individuals who are, still failing one of those three new acceptable screenings, you'll mark them a fail, list the color vision screening performed and the results in item 59, and issue the same class medical certificate as they previously held or a lower class with the appropriate 16 or 17 limitation, and you'll upload the eye color vision test. Next slide. So for your new pilots, first-time applicants with an exam occurring after January 1st, if they have passing results of any of the acceptable color vision screenings performed in person, item 52 should be marked a pass. You'll list the color vision that was performed, and then no color vision limitation is required because they passed, and you'll upload the eye color vision test. Next slide. And again, this is just the first time pilots that have never come through on this. If they have failing results of one of those acceptable color vision screenings or a screening that was not performed in person, you'll mark those as fail. You'll list the color vision screening and the results, and then you'll only issue them a third-class medical certificate with limitation 104, which is valid for day visual flight rules only. And you'll upload their eye color vision test as well. Next slide. Now, a new pilot that does not have color vision screening at the time of exam, in item 52, so if they don't have the color vision screening and you're unable to do that for them in your office, you will mark them as a fail. You'll list in item 59 that there was no color vision screening and issue them third class with that limitation 104. If the pilot presents after you've already transmitted that exam to us, you can upload the eye color vision test results and complete the eye color vision limitation. And with those passing results, we can issue them the class that they applied for without the color vision limitation if they're otherwise qualified. Next slide. So you heard me say a lot that the color vision screening must be uploaded. And that is correct. We do need those. We looked through the data. If you want to go to the next slide. And, you know, for the first month out of the gate, you guys did a fantastic job with uploading these. This is our first month to implement. So these are just January numbers, and these are only your first time applicants. About 67% had uploads with them. That number I looked at again today, and it's actually risen to 71% because you guys have uploaded more. Several of you I know spoke with our surveillance analysts from the regional offices over the last 2 weeks about the specific pilots that needed the eye color vision test uploaded. We pulled the numbers, and again, those have risen to 71%. So that is a really fantastic, right out of the gate, first month implementing this new policy. You may have seen the email earlier today to upload those color vision results for your first time applicants. If you're unable to get those uploaded, please let us know by reaching out to your program analyst or your surveillance analyst in the regions so that we can see what we can do to help you out. And then please work with your staff to get those screenings uploaded to the pilot's file. At the beginning of March, our office will begin sending out letters to first-time pilots that do not have color vision screening uploaded to their file. We are going to be starting with those cases that were performed in early January and requesting that they work with you in your office to have those results uploaded. And they'll be given a month to do that so that we can verify that all of those uploads are in there. Next slide. And so this is just a reminder on the general document upload for the AME. You can upload up to 25 documents per exam. Documents have to be right now less than 3 megabytes, 3 or less. And then there's several acceptable file types like the PDF, doc, JPEG, etc. One thing we have noticed is a lot of test results have been uploaded as those limitation reviews when they're just a test result, and most of the time they've been passing test results that we didn't need to look at. So just a reminder to upload your screening as eye color vision test. And then the document date is the date of service noted on the document. Next slide. So you guys are all probably familiar with AMCS technical support. Their email and phone number is here, but I also included their web page. On this web page, there's a quick start guide that's about a 15-minute video that takes users step by step on how to upload documents. So that's always a good thing for you or one of your staff members if they're trying to upload and are unfamiliar with the process. All right, next slide.
Just a shameless plug, if you have suggestions for improvements to the AME Guide, there is an email address on the screen on the slide, ameguide@faa.gov. Keep in mind that this email inbox does not answer case questions. Next slide, please. And a final reminder about requesting your CME. First off, if you've already requested CME for the session prior to today, you do not need to send another email. We already have your email. Second of all, if your first and last name were displayed during the Zoom session, you can send that email to AME, notifications@faa.gov. And be sure and include your first and last name as well as your AME number. And those certificates, give us a few days to get those out. We do have a basic AME seminar next week, so it may take us a little bit to get those out, but they will go. And also, if at some point in the future we're able to load this recording onto the YouTube channel and you're watching this as a recording, there is no credit that can be given for the recording. So that's all I have for tonight. Dr. Northrup, would you like to say anything before we wrap up?
Oh, sure. Why not? Let me start by saying thank you all for attending. Thank you for your patience as we're getting through some of the new policies. But just to let you all know, we did have a hiring of a significant number of physicians at the end of the summer into the fall, and those folks have become fully trained to the point where since the middle of November, we have reduced the unissued deferred cases in the queue by 10%, which is that's just a huge thing, despite the fact the exams coming in have not slowed down in the least. So we are on our way to getting better with the cases waiting for disposition. The general review physician's queue is down over 40%. So stand by, changes are coming, things are happening faster. And with that, I hope you all have a lovely evening, and we'll look forward to seeing you next month.